How's it going, guys? We have a past level question for Repro. 62-year-old woman, 1 month history of increasing fatigue. And we've got an image here that you need to be able to identify, which we'll talk about as we move through the clip. Which of the following is the most likely diagnosis? Choice A, dermoid cyst is wrong. Dermoid cyst is AKA mature cystic teratoma. It's the most common benign lesion of the ovary overall, and it's usually in youngish women, okay, teenagers up to around age 40. But they do not have to tell you hair, skin, teeth. They can just say a 40-year-old woman has a pulling sensation in the groin and ultrasound shows a calcified mass. So it can be calcific as well, dermoid cyst. Point is, wrong fucking answer. Choice B, dysgerminoma is wrong. Dysgerminoma is the seminoma equivalent in women. Okay, so for USMLE, you just need to know that it can be seen in Turner syndrome when there is a 45XO, 46XY mosaic pattern. I know it sounds nitpicky and weird, it's actually not. So you can just basically memorize if there's a mosaic Turner where there's Y chromosomal material, there's increased risk of dysgerminoma, and it's got LDH as a tumor marker. Point is, wrong fucking answer. Choice C, endometrial cancer is wrong. So most important / high yield thing you know for USMLE is that the biggest risk factor for endometrial cancer is unopposed estrogen. And this is a whole lengthy seminar as far as anovulation and polycystic ovarian syndrome. But you have to know that when women aren't ovulating, they're not making a corpus luteum. So your ruptured Graafian follicle is going to be called a corpus luteum, and it secretes progesterone. Now, not only will that maintain the endometrial lining if pregnancy occurs, but progesterone limits the growth of endometrium. Estrogen stimulates the growth of endometrium. So if you don't ovulate, such as with polycystic ovarian syndrome, then you get what's called unopposed estrogen because you don't have a corpus luteum if you're not ovulating. So you have estrogen stimulating endometrium, but you don't have progesterone there to limit the growth of endometrium. So that leads to endometrial hyperplasia and an increased risk of endometrial carcinoma later in life. So the women who get polycystic ovarian syndrome, it's usually high BMI. Doesn't have to be, but it usually is. So they'll give you a woman who's postmenopausal, let's say 58 years old, and she's had vaginal bleeding for the past 6 months, and she has high BMI, and it's endometrial biopsy is the next best step. If she's overweight postmenopausal, she was likely overweight through her life as well. So she had insulin resistance leading to polycystic ovarian syndrome and unopposed estrogen. Point is, wrong fucking answer. Choice D, mucinous cystadencarcinoma is wrong. So mucinous cystadenoma, the benign variant, and then mucinous cystadencarcinoma, the malignant variant, meaning it can metastasize. These both have a locular or loculated appearance grossly. Okay, and just what that means is it has cavities like honeycomb, so they can describe that, and also has intestinal-like epithelium. Now, mucinous cystadencarcinoma can also secrete a gelatinous substance, hence the name mucinous for both of these, but it occurs more robustly with the adenocarcinoma variant, and it can lead to peritoneal inflammation. It's called pseudomyxoma peritoni. It's fancy, it's low yield. Point is, wrong fucking answer. Choice C, Serous adenocarcinoma is correct answer. We're looking at psammoma bodies here. So psammoma bodies are calcified whorls, so concentric calcific masses. It's a type of dystrophic calcification, and there's many different types of cancers that can cause psammoma bodies. The ones you have to know for USMLE: serous cyst adenocarcinoma of the ovary, meningioma, mesothelioma, and papillary/papillary thyroid carcinoma. So you have these concentric whirls of calcium, very buzzy image. You just have to know the associations. Serous cyst adenoma, the benign variant, serous cyst adenoma, adenocarcinoma, the malignant variant, they can occur bilaterally. They can have fallopian tube like epithelium as well on histo, and samoma bodies as we have here. Correct answer.